Touching on a few points, we would like to remind you that the ECHO platform is built on kindness and respect to keep this a safe space for learning. If you have questions throughout the session, you can type them in the chat box, or you can wait until the Q&A session at the end and use the raise hand function, which can be found under the participants list. Please mute your microphone when you're not speaking, and remember to unmute before you speak. And finally, should you have any IT issues, just send a message through the chat function or email. Thank you. Now I'd like to hand it over to Dr. Massion.
Good morning, everybody. It's a great pleasure to discuss with you the pulmonary perspective of COVID-19 infection. I'm a pulmonologist and critical care specialist. I'm not an infectious disease doctor. I'm a regular doctor working in pulmonary and critical care with no pretension of major expertise, but I'm happy to provide with you with a review of the topic, and hopefully with Dr. Haile, we'll be able to answer questions of your interest. So the goal is really to understand how SARS infection happens and the mechanism of viral infection to the airway epithelium. We'll talk about presentation of patients, how we make a diagnosis, what are the imaging and pathology features of the disease, as well as the big challenge of how to recognize patients that need to be admitted on a ward versus an ICU. We'll talk about priorities for low and middle income countries, and we'll conclude with some key points and an open question and answer session. Next slide, please. So to start, wanted to give you a perspective of COVID-19 using some numbers. This is a virus that is an RNA virus in the family of coronavirus, as you well know. It is quite infectious on its own, and it takes on the airway epithelium from the nasal passages all the way to the alveolar space. It infects cells and takes the cells to their advantage to replicate the virus and propagate the infection itself. By doing so, it kills the airway epithelium that's infected in. The concentrations of the virus are very high, and we find them in the nasal passages, in the pharynx, in the throat. We find them in the sputum, of course, reflecting some of the bronchial airway and all the way to the alveolar space. And you find them in the stools and eventually in the urine. Next slide, please. So the virus has a property of being infective, as we all know, and it is measured by a reproductive number, which means that if one individual is infected, how many can that individual, in average, will be infecting? The numbers for this virus vary somewhat from study to study, but it is between 2 and 4, which is a large number. The viral infection starts at day 0, and patients remain asymptomatic for a long period. They are exposed, infected, making the virus, replicating the virus. They are contagious for 5 days without not knowing it. At the point they become symptomatic, the virus is in full course, and the symptoms declare themselves, usually first fairly mild, but eventually worsen, and in some cases lead to hospital admission, and eventually ICU admission and death. And I'm sad to say that we have now declared over 170,000 deaths of this virus since the epidemic started early in the year. This is a deadly virus with a case fatality rate that varies again between studies, but that is greater than one of influenza virus. And its primary mode of infectiousness, as you well know, is droplets. Droplets that are originating from the airways, generating by our breathing, our coughing, our chanting, or whatever it is, singing, and that is depositing in the air. Now, droplets can be big size. You can see them eventually, but many of them are microscopic, and they are in the air without you knowing. That is one of the most deceiving aspects of this viral infection, is that the virus can be present when patients are asymptomatic and quite infectious. Next slide, please. If you think about the presentation, they're not specific. There is no one typical presentation of COVID-19. You see the symptoms that are associated with the presentation published by our Chinese colleague out of their first 250 cases. They're very non-specific. We're talking about fever, cough, shortness of breath. Sputum production is not in everybody, headaches, or high temperatures. But what's a common denominator is that the vast majority of people who end up in the hospital have coexisting disorders. And we'll go over them in a minute. Now remember that 15 to up to 30% of patients infected with the virus will never develop symptoms, which is a big challenge when we are trying to do case finding. As you can imagine, if you're asymptomatic, good luck with finding these. The main mode of transmission is droplets, as I mentioned earlier. These are illustrated in the diagram on the right. These are droplets that are generated from any airway procedures that we do. Here are two procedures, intubation or bag mask ventilation. These are very prone to droplet generation and putting healthcare workers at risk in the environment. Other procedures that would be considered a high risk are those associated with coughing, of course, or bronchoscopy, or eventually placing a tracheostomy. All these require specific protective equipment to be placed and observed carefully. Next slide, please. So when and how do we make a diagnosis of pneumonia, and how do we bring patients either in the hospital on a regular ward, or when do we decide to bring them in the intensive care unit? Well, first we admit them on the ward based on history, based on the fact we're concerned that they're not ready to go home because they have eventually radiographic abnormalities. They may be hypoxic to some extent, but able to maintain oxygenation and O2 saturation above 92 on 4 liters of nasal cannula. People use this curve 65 algorithm to bring them patients with confusion, with uremia, with respiratory rate that's accelerated, or low blood pressure, or an age over 65 with a score over 2. Patients are considered to be hospitalized also when the consolidation of the cases of COVID-19 are coming in numbers, worrisome clinically, and yet we try to keep them in one area of the hospital, not anywhere, just to try to focus the area of, limit the area of infection overall. We need to monitor these patients regularly, as their respiratory status can impair over short periods of time. And very importantly, once in the hospital, we need to train practitioners in the ICU. We need to train them on the ward. We need to train them in the emergency room, in the operating room, and training is essential to be done and to be repeated over long periods of time during this pandemic. When do we bring them to the ICU? Well, the ICU is, of course, an indication when the hypoxemia is worsening. Patients cannot no longer maintain appropriate oxygen saturation just based on 4 liters of nasal cannula. When their mental status changes, when their lung diseases worsens, their respiratory worsens as well. We have a rule to try to intubate patients early on in the progression of the disease to avoid periods where they would have to be generating droplets in the air that would expose people at a greater risk again. We can bring them to the intensive care unit based on SOFA scores and many different metrics. But the bottom line is that the MICU mortality varies between 30 to 50% in case series that have been described so far. One of the big challenges in the ICU is to get these patients over the intubation period. Early extubation, like we hope to do, is very challenging. ECMO is extremely resource intensive and not at the forefront of this disease when considered in low middle income countries, for sure. Next slide, please. I want to give you some idea of pulmonary imaging and chest imaging representation of the viral infection. On the left-hand side, this chest X-ray demonstrates some mild pulmonary infiltrates in lower lung fields, particularly in the right and the left lower lobes. On the right-hand side, the situation is much more dismal. The patient is intubated, has a central line, and as you see, they are diffuse patchy pulmonary infiltrates bilaterally, very much diagnostic for ARDS, acute respiratory distress syndrome, particularly if the patient is not in heart failure. Next slide, please. Now, I mentioned that up to 30% of individuals presenting with COVID-19 are asymptomatic, and actually many of them don't have pulmonary manifestation on imaging. Here I'm showing some images of a chest CT that is not normal, that demonstrates very clearly small patchy infiltrates. We call them ground glass opacities, just because it looks like looking through a ground glass. These are alveolar filling of inflammatory cells and fluid that has leaked in the alveolar space. The case is very mild in this particular representation. Next slide, please. The virus can present many different ways. It could be a reticular pattern like you see on the left, or on the right, a crazy paving pattern that you see on this large rectangle circled in red. Next slide, please. Other presentations include pleural disease, pleural thickening at the top left and bottom left, as well as a slight and discrete fibrous type arrows on the B figure on the top right, or large ground glass opacities with a center density on the D panel. Next slide, please. Another presentation is nodular densities. These are sometimes less worrisome, but they can progress. But you see these nodule densities can appear as part solid, or eventually again, a ground glass opacity that's commonly identified in these individuals. Next slide, please. Patients with COVID-19 can present with mediastinal adenopathy only, and you see them nicely depicted by these arrows, white arrows on the enlargement on the right-hand side. Next slide, please. But commonly, this is what we're dealing with here. ARDS, diffuse patchy infiltrates, peripheral in the lung, involving all 5 lobes. Next slide, please. There is very little known about the pathology of this virus and how it presents under the microscope after tissue specimens have been recovered. This is one example of such that was published in JTO just recently. What you see are these proteinaceous, alnaceous exudates in the alveolar space, and these globules like you see in the B figure. These are protein material that are accumulated in the airways. And more typical of airway disease is this vast inflammatory response with white blood cells that are accumulating, as well as epithelial cells on the bottom right and large in a green rectangle, illustrating now an epithelial cell that is infected with viral particles, and they called nuclear cytoplasmic inclusions. Next slide, please. Let's talk briefly about comorbidities and its relevance in this disease. Comorbidities are a high predictor of worsened outcome. In this nice series, again published in the New England Journal of Medicine, you see, or in the European Respiratory Journal, rather, I'm sorry, you see that some of these comorbidities are clearly associated with increased hazard ratio for death. And the one that you see that are the most prominent are the presence of chronic obstructive pulmonary disease, diabetes, hypertension, or a malignancy. If you are affected, a patient is affected with one of these comorbidities, the hazard ratio climbs up to 1.789, but two or more has a definite additive effect to up to 2.5 or even greater. On the right-hand side, you see that the mortality rate, the failure rate of these patients to survive over time, increases dramatically with the number of comorbidities. Next slide, please. We're trying to measure severity on admission and to try to gauge as to whether the patient needs to be in the intensive care unit or not, particularly when our resources are limited. Clinical judgments probably prevails. Some biomarkers could be used, like elevation of D-dimers, CRP, LDH, and you see the list like I do here with troponin elevation, ferritin elevation, or CPKs. An important one is a decrease in lymphocyte count, which seems to be another marker of severity. Next slide, please. Let's talk briefly about treatment. I find treatment of COVID-19 the most frustrating topic. Frustrating because the truth in the bottom is that there is, to date, no standard of care that is recognized to efficiently affect the progression and the infection of this virus. There is no established treatment for COVID-19 as of yet. So how do we handle this? Well, we'll take general measures. We consider empiric treatment for community-acquired pneumonia. And based on severity, we admit these patients to the hospital. Remember that the vast majority of cases that have been described don't show evidence for bacterial supra-infection. So, extensive antibiotic coverage in patients with proven COVID-19 have not been common practices in most of our centers. DVD prophylaxis is actually debated but recommended. Low molecular weight heparin is administered to these patients. We know that the virus is associated with increased microthrombotic disease, and DVD prophylaxis may help them. We need to combat fever. We like to use acetaminophen preferentially. There is some suggestion that NSAIDs may be of a risk, but the data is not definitive. The inhaled therapy is preferred with metered dose inhalers as opposed to nebulized therapy. Why? Well, simply to decrease the risk of nebulizing droplets, again, that are loaded with COVID-19 virus. There is no good evidence for glucocorticoids to be helpful early in the onset of the disease, but they should not be stopped in asthmatics or people with chronic pulmonary diseases if there's a treatment that stabilizes their disease. Corticosteroids may be considered in the advanced stage of the disease when this dramatic inflammatory response is overwhelming. ACE inhibitors have been considered and questioned as whether we should continue prescribing them, as the ACE2 protein facilitates entry of the virus. Statins also have been questioned, but at the moment there is no strong guidelines to prevent your patients from getting these medications unless their blood pressure is low, for example, for an ACE inhibitor, or they have liver abnormality based on a statin treatment. Immunosuppressive therapy, we should try to avoid them if we can, as we know that the T cell count is associated with prognosis. A low T cell count, lymphopenia, is of concern. Next slide, please. So where is the hope? The hope is that in a landscape where we don't have any current treatment available, some will rise to the front. And all of you have probably heard about a series of these therapeutics: remdesivir, convalescent plasma, hydroxychloroquine, IL-6 inhibitors, and all these treatments that we could add some of them to the list, like zinc or anticoagulation. But the bottom line here is that we are trying to demonstrate efficacy and interfering with the viral entry into cells, its replication machinery that takes over the cell machinery to its own advantage. We're trying to prevent the virus to eventually assemble and being exocytosed. Now, these, the diagram on the left-hand side gives you some hints as to where this is trying to be targeted and at what level of the viral replication cycle. But the main point I would like to make here is that we're not trying to treat just one disease here. We may try to fight at least two main diseases. One is the viral infection itself, and we can try to prevent them from entering or from replicating. But we're also trying to treat a very prominent inflammatory disease that eventually kills patients. And this inflammatory disease is very overwhelming and sometimes leads to death. So remdesivir is this viral nucleoside that eventually inhibitor that prevents viral replication that is in clinical trials. So is hydroxychloroquine. Hydroxychloroquine is widely used for malaria treatment and prophylaxis, as we know, but the drug has some effect again on inhibiting viral entry, and the definite evidence for that drug to provide benefit is not established in a absolute manner in randomized trials. There are a lot of studies that are currently ongoing, and we encourage all of you who are able to contribute to clinical research to do so. There's been a lot of discussion about convalescent plasma in the press lately. The idea is that the circulating blocking antibodies to COVID-19 in a patient who is recovering from the disease may be protective in another individual. This is a commonly thought process, and yet no evidence has been brought to the clinical front as of yet. Large studies are ongoing as well, and we should hear from those pretty quickly. The IL-6 inhibitor, tocilizumab, is a drug that prevents or tries to prevent this wild inflammatory disease that is associated with more advanced infection of the lung in particular. So all these molecular strategies have good rationale, but we have to be patient and honest about the lack of evidence to support their formal use and when to use them, at what point in the viral infection. Should we bring them early in the disease space, or rather keep them for more advanced cases? All these are very legitimate questions that need to be answered urgently. We haven't discussed very much oxygen therapy, but obviously for this pneumonia, which we are very common with as pulmonologists and intensive care specialists, we treat pneumonia every day. This one is a pneumonia that is associated with hypoxia, sometimes very profound. So how do we deal with hypoxia? Well, we give oxygen. How do we give oxygen? We give oxygen with nasal cannula, and we eventually recourse to the high-flow nasal cannula. There are discussions as to whether high-flow nasal cannula may increase the droplet generation when patients are breathing in and out of these devices. There's no good evidence for that. Again, it's an area of investigation that we will know more about pretty soon. What about non-invasive ventilation? BiPAP machines or CPAP machines are sometimes used with oxygen to limit their intubation rate. Now, these devices are in open circuit with the air, meaning when the patient breathes in, the patient breathes out, the exhale valve goes in the ambient air around the patient and increase the risk for infection of healthcare workers. So we have had so far the policy of considering early intubation and not using non-invasive ventilation for temporizing measures and trying to avoid intubations, as it is practiced in many cases for other diseases, including COPD exacerbation or congestive heart failure, just to name a few. ECMO has very little role in this disease, at least in low to middle income countries, settings where the resources are limited, we understand. And I still have to see a patient who survives COVID-19 after being put on ECMO. Next slide, please. So the challenges are many. And the problems that we are facing also relate to how we organize ourselves in the institutions that we are working with. What are the number of beds that are available? Are they sufficient or not? What about the number of ventilators? Can we increase the number of ventilators? Can we turn some anesthesia machine into ventilators? What about the number of specialists to take care of these patients on the ventilator? Do we have enough ICU specialists, nurses, and respiratory therapists around to help? How can we afford this in low middle income countries? These are questions that some of you are asking yourself now and trying to do your best. I think it's important to recognize that we have a lot of respect for all the scenarios that you are facing. There's no right and wrong answer. We understand we all want to do our best for the larger number of people possible. So we need to prioritize eventually. I have not had to face that problem of prioritization yet, and I'm glad I didn't have to. It's a difficult thing to do. Do we base prioritization on age, on comorbidities, or on patients' wishes? These are difficult considerations. Next slide, please. Ethical questions come all the time in these situations where we need to do some triaging of ICU care. It's a very complex problem and it's emotionally draining, very difficult times. We need to prioritize eventually based on physiological outcomes. And we can try to predict morbidity and mortality on patients. And yet, you remember that our scoring systems are inaccurate and many patients fall off the typical predictions. The shared decision-making and attending the patient's wishes is really critical and yet cannot be always respected depending on the circumstances, the volume, and the resources available. So we're trying to provide the best for the most people. We want to respect standards of fairness, duty, transparency, proportionality, and accountability. This is part of our oath of professionalism. In addition, we understand our limitations, and we have to understand and discuss this with hospital administrators very carefully. What are the resource limitations? What are the institutional constraints? How can we collaborate with other institutions who may be better equipped or able to absorb larger volumes? And we need to keep our commitments to family in very difficult times. A lot of people say that the time you get intubated, say goodbye to your family, you won't come back. There's a lot of emotional support that needs to be provided. People know what this virus can do. and dealing with solitude in the ICU can be extremely difficult. Next slide, please. So when we're making choices in low to middle income countries, I'll be very interested to have your own perspective on this. But I think there are some roles here. We need to realize that we want to avoid putting ourselves at high risk because we need to provide the service needed for long periods of time. This is not a race we're going against. This is a marathon. It's going to be a very long pandemic. We're talking about months and maybe years. It will have profound impact on ourselves. People say that we won't have an opportunity to be exactly back as to where we were after the pandemic. What exactly means, we're not totally sure, but we know that the impact on healthcare is tremendous. We need to respect social distancing, as we know it works extremely well. Beautiful examples in Hong Kong, for example, in different parts, different cities in the world, where social distancing have been imposed early on with very low infectious rate. Sheltering in places, wearing protective equipment as directed, taking them off, and then very importantly, education. We as health professionals have a big role in education and in helping people understand what it means to have case finding. When we find a case, we may have to eventually trace this contact. Not only trace this person, isolate the person, put them on quarantine, and eventually decrease the replicative numbers. Next slide, please. So we're finishing with my presentation with understanding that you're making hard choices. And on behalf of all of us who are working in this space, and particularly for all of you who are listening today, I want to thank you for what service you provide to the community and to your patients. This is a hard time. You need to try to protect yourself, and you have to protect your healthcare workers as healthcare hospital administrators for sure. We need to stop the spreading of these, the germ, and basic rules, not shaking hands, coughing in handkerchief, wearing your mask, cleaning the surfaces, and isolating people, washing your hands regularly. The basic measures do work and need to be implemented preventively. Next slide, please. So I have a series of references here. It's not exhaustive, there's many more, but it's at least a way to start if you're interested. Next slide, please. I want to finish with these few key points. We all in this on the long run. This is a very difficult pandemic. We're dealing as pulmonologists and critical care specialists with a disease we know very well. This is viral pneumonia. This is not that complicated, and yet we go to the moon, we do amazing things, but we don't know how to treat this virus. Droplets is the enemy. It is the main mode of transmission. We want to reduce aerosolization, and we want to wash our hands. We have to be clear, there is no specific treatment to date for this disease. There's a lot of clinical trials ongoing, and I encourage all of you to participate in them if you can. You need to protect your healthcare workers and try not to abandon evidence-based practices when appropriate. Please push on education, prevention, and facilitate clinical research. And with this, it's my pleasure to share the next part of this discussion today with Dr. Teddy Haile Gebremariam, who is Chair of Medicine and a pulmonologist at Tewodros in Addis Ababa. So we'll try to answer some of your questions, and I thank you for your attention.
Thank you, Dr. Massion. That was great. We appreciate you coming on and sharing that presentation with us. Dr. Gebremariam, would you like to share maybe your experience to date dealing with COVID-19 in Ethiopia?
Okay, first of all, I would like to thank the organizers and Dr. Massion for the excellent presentation. With regard to our experience here in Ethiopia, So far, we have not more than 112 patients, and these are all kept in one center. We have a dedicated center for COVID treatment. It's a newly built hospital for other purpose, but it's converted to COVID management. And so far, we have only 3 cases. They all died of respiratory failure. They were intubated, but couldn't be rescued. And the rest are mostly mild to moderate, and we were able to manage some 3 or 4 other patients in the ICU. So far, we don't have any problem with handling the cases because there are only limited number of patients. But if the pandemic, in Africa increases and the number of patients increases, probably will suffer a lot because of the limited ICU beds and limited ventilators we have. And also, even for that matter, limited oxygen supply in the country, and also PPEs, personal protective equipments, are also limited in number. So, but so far we are doing good. And also with regard to social distancing, the government has imposed a lot of measures, even though the comply from the people is a little bit difficult with regard to the distancing, the 2-meter distancing. But so far, most of our cases are imported cases and cases who have contact with confirmed COVID cases. So I think we are in this state, and just I can later on add when I'm asked. Thank you.
Thank you, Dr. Gebremariam. We're going to go into a time of question and answers. Please feel free to type your questions into the chat if you have any, or you can use the raise hand function. And at this point, I'd like to pass it over to my colleague, Monica.
Hi, everyone. Thank you. Thank you so much to the presenters, Dr. Massion and Dr. Tewodros. We have some questions that came in from pre-registration, as well as some that have come in throughout the session. So I'm just going to start running through them. They're going to be to both of you. So please feel free both to respond to these questions. So the first question, when does the exhalation cloud become non-infectious once a patient is declared cured?
Yeah, maybe I can take that one. It's a difficult question to answer because there's insufficient data to certify that a patient has been definitely cured from the virus. There are guidelines that are put together to have time after infection being diagnosed up to 14 days and evidence of absence of a PCR testing repeated eventually once. These are guidelines that are difficult to implement, but people have recovered RNA molecules up to 2 months after the infection. That doesn't mean that the patients are necessarily infectious, because RNA particles are different from live viruses, but it is quite concerning. So we actually don't really have a good answer as to when we can fully declare somebody cured. Now, we have to deal with life in general, and therefore the CDC guidelines that are put together now allow us to bring patients back to out of confinement, out of isolation, typically after 2 weeks and being tested negative.
Great. Thank you. Dr. Tewodros, I'll ask this next question of you, but again, please, either of you can respond to these. Can you comment on the role of convalescent plasma in the treatment of COVID-19?
Actually, we don't have the experience yet here. Probably Dr. Nelson.
So convalescent plasma is also an area of active research. There are clinical trials throughout the world. It basically is the concept that having blocking antibodies to COVID-19 in the circulation of the patient who's recovering and providing another individual with these proteins that may prevent the virus from replicating. The idea is conceptually very satisfying, and yet the evidence is not present yet. This is in a research setting at the moment. It's not particularly difficult actually to implement should you have a blood bank that's pretty up to speed, and yet it requires quite a bit of resources, and that's inevitable when it comes to plasmapheresis and eventually injection of these types of products.
Great, thank you. Next question is, if we do not have COVID testing, should we do CXR to help diagnose the virus? What vital signs should we follow if we do not have enough pulse oximeters? And do we have parameters for our nurses to call the physicians for seeing that patient?
Okay, let me try. With regard to the use of chest X-ray in the diagnosis of COVID, when the PCR, the real-time PCR is negative, chest X-ray is said to have a sensitivity of 60%, particularly when the disease are at advanced stage. But if CT scan is available, that has got better sensitivity, like 97%, even though it's low specific. So we can use that, but the other option is also to use specimens from the lower respiratory tract. They are more productive, just you can find the virus from that. The other question is with regard to in the absence of pulse oximeter, what vital signs to use. Yeah, we can use respiratory rate, use of accessory masses, blood pressure, temperature, and the like. But even counting the respiratory rate and observing the, the use of accessory muscles may not be sensitive enough to pick particularly the silent hypoxemia that these patients are having. So, even though you can use those parameters or vital signs, you need to have pulse oximeter, particularly in a patient who is diagnosed with pneumonia, to pick early the hypoxemia that these patients are suffering, as most of them are dying of the respiratory failure. And what was the last question? Excuse me.
The last question, yes, thank you, is do we have parameters for our nurses to call the physicians for seeing the patient?
Yeah, that's what I try to address. Yeah, it's very difficult to depend on vital signs only. You have to use pulse oximeter.
Yeah, okay, thank you. The next question again to both of you, is there, your thoughts on this, is there a universal definition of recovery, quote unquote? Is everyone using the same criteria, and is this the same criteria for discharging COVID-19 patients?
I can take a first stab at this, Ted, if you want. I think there's no one definition of recovery as of yet. We don't have enough experience behind this. And recovery of a patient with mild symptoms versus a recovery of a patient who has stayed for 25 days in the ICU, obviously is going to be very different. But there is a infection. What really matters is that the patient gets better. That's one, that's recovery. That's a clinical one. It's probably the most important. But on the infectious disease standpoint, another important parameters of recovery is making sure that the patient is no longer infectious. This is where it's going to be difficult because, as we mentioned earlier, some viral particles or DNA or RNA rather of the virus can be recovered a long time after the infection has been present. We need more data, more study. We need to be able to test broadly people for recovery. There are lots of discussions about the possibility of testing for antibodies that have been generated in these individuals. And the presence of immunoglobulins against the COVID-19 may be a sign of recovery. And whether they're fully blocking antibodies is not totally sure either at the moment. So it's a very difficult question, and I think that we'll know a lot more in the weeks to months to come.
Great, thank you. Another question that came in from the pre-registration, does lung fibrosis caused by COVID-19 reverse after recovery? And if so, or if yes, how long does it take?
Lung fibrosis does not get better after COVID-19. I'm not sure I understand the question right, but lung fibrosis is a risk factor for poor outcome in the presence of this viral pneumonia. Should a patient with pulmonary fibrosis suffer from this virus, the odds of mortality are greatly increased. I'm not aware of the viral infection to affect otherwise the fibrotic response that is ongoing in patients with pulmonary fibrosis.
Okay. In a setting where we have limited ventilators, who should we ventilate based upon some parameters in the patient? And do we ventilate anyone, or do we have to pick specific patients?
Teddy, do you want to take that one?
Well, we have not yet faced this problem, but the Ministry of Health has issued a guidance on that based on some ethical consideration, and as it has been done elsewhere, the age of the patient, comorbid conditions, and overall performance and complications of the disease should be taken into consideration to prioritize ventilators, but we have not yet reached to that stage. Thank you.
Some people were faced with this issue, and this is most difficult. And again, we mentioned earlier, is ethically difficult and emotionally draining, and we have to very much respect the integrity of all healthcare workers trying to do their best. There's, in these difficult settings, there is not necessarily right and wrong answers. It is to try to do the best for the majority of the patients. And yet, at some point in Italy or in Iran or in many other countries, people have had to make choices based on risk factors. Age and comorbidities associated with the presentation puts people at much higher risk. And if we naturally, we would have to deal with a person that's elderly with multiple comorbidities to a pregnant woman, for example, we know where the priority is going to be. Now, again, we have to be extremely respectful of everybody's clinical judgment and intention to do best for the most.
Thank you both. Can you, Dr. Massion, in our last session, you spoke to proning and the benefits that we're seeing from that. Can you speak a little bit more to that?
Sure. So pronation involves moving the patients to lie on their belly instead of on their back. There are beds who do this automatically, that they rotate, but most people just flip patients in a prone position. You know, there are some contraindication to this with facial trauma, for example, or inability to have a stable spine and things like this. But for the vast majority of people presenting with this virus, proning may help us in dealing with profound hypoxemia. There are clinical trials that demonstrate the efficacy of proning for hours over a cycle of 24 hours, up to 16, 17 hours a day, putting people on prone positions so that the areas of the lung that are ventilating well and are perfused well are more active. The idea of this proning actually is not new. This is an old ICU measure that the people are trying to implement, particularly with ARDS, acute respiratory distress syndrome. It is technically challenging for the nursing staff. We need to access central lines in different ways. It requires a lot of preparation and training on the nursing side as well as the physician side. We typically do this, prone people for an hour and see how they behave, how they handle it. We turn them back if needed, but otherwise we try to prone them for a prolonged period of time. We are dealing with VQ mismatch in the airways. We're dealing with hypoxemia, and areas that are flooded with infection or inflammation or fluid typically don't contribute to gas exchange. When the areas are more prone and more healthy, not so much dependent on gravity, are spared by this process, when you flip the patients around, you allow the normal lung to do more of its job. So this is the idea. I think that for the interest of the group, it would be great to actually share a proning positioning protocol that's commonly practiced in many of our hospitals. And if you wish, I can help you with that.
I want to add on that. Actually, the prone positioning in ventilated patient is the one which the professor was mentioning. But I'm having some information also, some older or new publications that the use of prone positioning in patients who are awake and non-ventilated. So what's your experience on that? Just a colleague from New York told me that they are using that and it's helping, you know, just to avoid intubation and something like that. I think these are the things that can help people, physicians from resource limited settings. So we are planning also probably to implement that, and even a few hours of prone positioning, like 2 hours per day, has helped. And there are 2 publications, one for older time and one a new one, and that may be also helpful in patients who are awake and non-ventilated.
Yeah, I think that's a great suggestion. Thank you.
The next question is, in recent findings, there were patients with negative RT-PCR, but typical imaging findings of COVID-19. Is there a different protocol follow-up for this group of patients?
Yeah, in our practice, when patients have finding suggestive of COVID-19 by X-ray, by clinical presentation, and a negative PCR test, we treat them as if they had COVID-19, particularly if they had to stay in the hospital. So, you know, there are some false negative with the test. The false negative test depends on the PCR test that's been used, can be as high as 20 or 30%. So it's not unusual. And yet, the test can be repeated eventually if it's possible. But we have to be on the preventive side of the equation here, meaning that if a patient presents and you have a very high suspicion of COVID-19 with a negative test, you still should consider the patient to be put in quarantine until the next 14 days. That's our practice here, at least.
Great, thank you. This is a more general question, but it just came in, and really this is to both of you. There's debate on herd immunity. What are your views in terms of the virulence and potency of coronavirus to allow for discussions on herd immunity and loosening up on lockdowns?
Teddy, do you want to take that one?
Maybe more of a political question.
Okay, let me try. I think the people are now utilizing this antibody tests, serological tests, to determine the rate of infection, and to decide. Probably governments are getting interested on planning to loosen the lockdown and everything, and there are 2 studies from US, one in Massachusetts and one in Santa Clara, California, which shows that 1/3 of the population has positive antibody test, which means that these people have been exposed to the virus. So that may help if the people more than 60% to 80% are having the antibody already. That means that even though it's not well studied and well confirmed for how much time the antibody will stay, so that may help in the decision and can guarantee to some extent herd immunity. That's the thought, but I'm not sure on this, Professor.
I think one of the general comments from public health advocates is that we will need to do a lot more clinical testing of the presence of the virus and immunity against the virus to be able to better assess whether we can relax social distancing in a significant way. Right now, we're still in the dark. We don't really know and understand fully what does it mean to have the presence of immunoglobulins against COVID-19. Does it fully protect you? Does it protect you against a reinfection? Does it mean that you're no longer virulent? All these questions are not quite clear yet. But general testing in the population is very resource intensive, costly, and difficult to implement. And it will take time for the industry to come up with a test that is cheap, readily available, and that would allow then to not only identifying the cases, but it will push healthcare providers and public health offices to trace these individuals, trace these contacts. That by itself is extremely resource intensive too. And I'm not sure how middle to low income countries are eventually prepared to do that. Teddy, do you want to comment on that?
That's actually what our public health institute is doing. But as you said, it's very resource intensive. It takes time, but because the number of infections that are identified in our country are small, so they are trying to trace. As recent as few days, there was a woman who was diagnosed with COVID-19, and she is living in one of the regions. So she came from Lebanon, and she stayed in that area and this region for a month. So she had several contacts, and it was very difficult to trace everybody. She has traveled in several regions of Ethiopia, so it has been very difficult. But that's what they are doing, contact tracing, and probably they may also consider looking that local area, and they are really suffering the public health.
Thank you. I want to be cognizant of everyone's time, so we're going to wrap up shortly. We did receive a lot more questions, and we will be sharing then with the doctors to hopefully get some additional information for them, which we can share on both the Assist International and the Vanderbilt Institute for Global Health websites. Let me just hand it over to both Dr. Massion and Dr. Tewodros to say any final thoughts that they would like to share with us.
I guess I can start, Ted. I would say that we are all in together. This is very difficult that you're in a low middle income country, high resource country. This virus does not prejudice yourselves against who you are, but low to middle income countries are going to be higher risk for higher mortality. So there is a responsibility of the international community, in my opinion, to facilitate and help preventive measures and therapeutic measures in these low resource settings. I would also say that although there is no treatment right now, there's tremendous effort being done internationally, and globalization has helped us with that, sharing data, participating in clinical trials in many different countries to advance the science very, very fast. And I'm very hopeful that we'll have a treatment. Maybe we'll have a treatment before we had a prevention or a vaccine. Vaccine generation is difficult. We don't even have a vaccine for HIV 30 years later. We don't have a vaccine for RSV virus. We don't have vaccines for so many other viruses. It's very difficult and challenging, but we have to press on that and hopefully participate in clinical research if we can. And then finally, I want to say that we're in here for the long haul. This is not going to be fast. This is going to be a very long process. We are concerned about a resurgence of other boosts of epidemics of this virus, and reinfection rates may be, or infection rates of new population may be high risk, particularly in the elderly. We may have to face confinement and isolation for a prolonged period of time. So we need to get prepared for a change in mentality, how we interact with one another, and how we handle preventive measures. But if we can be of any help, please let us know.
Okay, thank you. I agree with Professor. I think we are going to embrace this pandemic in Africa in a month or two. Well, in one sense, the fact that it's delayed give us an advantage to get prepared, to take lessons from you guys. And I think organizing such webinar will help us, to take a lot of lessons from what you have done, and that will give us also, all the preparations on how to handle our patients. And the other thing that we have to focus as an Africans is more on prevention. I think probably it is a measure that our governments are taking is probably pushing the epidemic further, and probably if we do so and if we remain disciplined, I think we can have a smaller peak. So we have to work hard on prevention, social distancing, quarantine, and the like. And once we have the patients, we'll do all what is possible with us, but with limited resource, and we have to be able to protect our health workers. And I think by doing so, we can decrease the mortality. That's why the hope we have. And it's good to establish, leadership at each level, from the Ministry of Health level to the smallest units, to tackle this problem, and also to have partnership with people like you. And I would like to thank you again for organizing such a nice presentation. Thank you.
Absolutely. Thanks to both of you. And I just want to thank both of our presenters today, Vanderbilt University Medical Center and the Vanderbilt Institute for Global Health for putting this together, as well as GE Foundation for helping make all of this possible. I'm going to pass this along to my colleague Chase now to close out the session.
Thanks, Monica. And I would like to echo everything that you just said. Thanks to all of the people who have helped with this. And thank you to all of our participants as well. I'm going to share a QR code with everybody real fast. This will take you to a WhatsApp chat that you can use if you have any other questions, to share your experiences or any other things like that. And if you have time, I know we've gone over a little bit, but if you have time, I'm also going to be sharing a short poll. And if you have time to fill that out before you leave, we would greatly appreciate that as well. So thank you once again to everybody. And we hope to see you guys again in a few days.
Thank you. Thank you, Ted.
Thank you. Thank you.
Thank you, guys.
Thank you.
Thank you from Bugando Hub.
So,
Thank you, Kevin.
hello. Okay.